For decades, the prevailing model of back pain therapy, particularly for conditions like degenerative disc disease, spinal stenosis, or spondylolisthesis, has centered on mechanical correction. When conservative measures fail, surgery has often been the final recourse. Spinal fusion to stabilize, laminectomy to decompress, or disc replacement to restore lost height and motion. These procedures have undoubtedly improved quality of life for many, but they are invasive, expensive, and not without long-term risks. The assumption has long been that once the spine begins to break down structurally, physical repair is the only viable path forward. But a growing body of research in cellular biology and pharmacological therapy is now challenging that assumption. We may be on the cusp of a paradigm shift, one in which the future of back pain treatment involves pills, injections, and cellular reprogramming rather than screws, rods, and scalpels. At the heart of this evolution is a deeper understanding of what drives degeneration in the first place. Rather than seeing disc breakdown or joint collapse purely as a result of biomechanical wear, scientists now recognize a central role for chronic inflammation, cellular senescence, oxidative stress, and metabolic imbalance. These processes degrade tissue long before visible structural collapse occurs, and they often continue unabated after surgery, explaining why some patients experience recurrent pain or adjacent segment disease even after seemingly successful procedures. This new biological framework has ushered in a wave of non-invasive or minimally invasive interventions aimed at modulating the microenvironment of the spine. One of the most promising directions is the use of senolytic drugs to selectively eliminate senescent cells, those dysfunctional, pro-inflammatory zombie cells that accumulate in aging or stress spinal discs and joints. Early animal studies show that clearing these cells can reduce inflammation, preserve disc height, and even reverse some aspects of degeneration. Trials in humans are in their early days, but the concept is groundbreaking. Rather than cutting out damaged tissue, we might pharmacologically restore it to a more functional, less inflammatory state. In parallel, stem cell therapies are advancing, especially those using mesenchymal stem cells, MSCs, delivered directly into degenerated discs. These cells don't necessarily become new disc tissue themselves, but they release trophic factors that suppress inflammation, modulate immune responses, and stimulate endogenous repair mechanisms. While not yet a replacement for end-stage surgical intervention, MSC therapies may offer a regenerative option for patients in the early to mid stages of disc disease, potentially delaying or avoiding surgery altogether. Gene therapy and RNA-based treatments are also entering the conversation. Experimental work is exploring how to upregulate protective proteins or silence destructive enzymes in spinal tissues. These molecular interventions target the root biochemical causes of degeneration and could, in time, be delivered via injection or implantable devices. Unlike surgery, which addresses symptoms by mechanically modifying anatomy, these treatments aim to reverse or arrest the underlying biology of degeneration, addressing cause, not just consequence. Even more traditional pharmacology is being reimagined. For example, targeted anti-inflammatory compounds, nerve growth inhibitors, or biologics that block specific cytokines, such as IL-1 SET or TNFA, are under investigation as more refined alternatives to broad-spectrum NSAIDs or corticosteroids. The future could involve precision-matched drugs based on biomarkers or imaging that indicate specific inflammatory pathways active in a given patient's spine. That said, this shift from surgical to pharmacological and cellular therapies is not without debate. One of the major arguments in favor of surgery is its predictability in certain cases. When there is gross instability, severe nerve compression, or anatomical deformity, structural correction may be necessary and appropriate. Cellular therapies cannot yet realign a spine or decompress a nerve root that is physically entrapped. Additionally, many of the regenerative and senolytic treatments are still in preclinical or early clinical phases, and long-term efficacy and safety remain to be proven. Dosing, delivery mechanisms, and patient selection criteria will need refinement. However, the potential benefits of this shift are profound. Avoiding or delaying invasive surgery means less risk, lower cost, shorter recovery, and fewer long-term complications like hardware failure or adjacent segment disease. Moreover, pharmacological and cellular approaches may offer more holistic system-wide improvements, reducing not just local pain but the inflammatory and degenerative processes that affect multiple joints, tissues, and even the nervous system. The most likely future will not be an either-or model, but a hybrid, where pharmacological and regenerative treatments are used to stabilize and slow progression, while surgery is reserved for acute structural crises. For many patients, especially those in the early or moderate stages of back degeneration, this could mean managing their condition effectively for years or decades without ever needing the operating room. In this emerging vision of spinal care, pills and precision biologics may one day take center stage. The scalpel will still have its place, but increasingly, it may be used not as a first-line intervention, but as a final measure, once all avenues of regeneration and cellular correction have been explored. It is a future of spinal medicine that is less about cutting and more about healing, one that recognizes the spine not just as a mechanical structure, but as a living, adaptable system capable of renewal if given the right tools.